Hello, my name's Julian. Welcome to part 2 of approaching the acute abdomen. So we've already spoken about a few things in part 1, namely the context of acute abdominal pain in the emergency department, a bit about anatomy and physiology of pain, a bit of an approach with history and examination to the acute abdomen, and some of our investigations and why they're sometimes not as useful as we think. Part 2 today is looking at some of the worst first considerations. This is by no means a thorough, comprehensive covering of all the different things that cause abdominal pain and can be life-threatening for you, but I'm just covering some of the main ones to think about. Some considerations for the elderly populations that we see, very important. Considerations for disposition. Can this person go home? Do they need to come into hospital? And then just some pearls to take home. Alright, so considering a worst first approach. So we know that in the abdomen you've got different systems, vascular, gastrointestinal, there's a bit of pulmonary from the upper part of your abdomen, lots of different areas within there. So looking at vascular first of all, mesenteric ischemia is something that has a potentially very high mortality rate. In terms of the arterial supply of the intra-abdominal viscera, particularly the intestines, celiac trunk, superior mesenteric artery, and the inferior mesenteric artery. Just like any other artery in your body, these can have plaques or emboli. Basically, if anything disrupts the blood flow through any of these arteries, you can have downstream ischemia and subsequent pain from that. The most common artery to be affected by this is the superior mesenteric artery, which tends to affect the vast majority of the colon around here. So in terms of the types of ischemia, we've got 4 primary types of ischemia. Arterial embolism, which I'm going to talk about in a second, but the first one is plaque or thrombus. So a thrombus within one of your arteries in your abdomen, just like a coronary plaque within one of your coronary arteries, can cause angina, just like in your chest. So postprandial angina, you've eaten something, there's an increased requirement of oxygenation and blood to the gut to deal with all the food, you can then get an onset of pain. That may sometimes evolve to an acute worsening of pain with an embolism. If you get a rupture of one of these plaques, that can fire off and block one of the downstream vessels, and that can lead to an acute arterial embolism. It's a very high mortality rate. You get pain wildly out of proportion with the examination findings. It may be difficult to pin down where the pain is. You may have nausea, vomiting, diarrhea, bloody stool. Be particularly aware if somebody's got known atrial fibrillation, known embolic disease, particularly if they're not anticoagulated, very concerning. So that's these two, thrombotic and embolic. And then we've got non-occlusive mesenteric ischemia down here. So you can see that this sort of represents or indicates vasospasm of the arteries. And that can come about from hypoperfused states like sepsis, heart failure. If you're deplete of intravascular volume, that can lead to ischemia, like a type 2 MI, for example, would. And then D down here, this is like a venous congestion or venous thrombus, so a bit more indolent, similar to like a DVT. You can have these if you have risk factors of portal hypertension, hypercoagulability, if you have some of the same risk factors of DVTs really, and that can have this coming and going abdominal pain that can get worse over time. So in terms of how we find out whether someone has got mesenteric ischemia, the first thing to say is we need to be thinking about it, because lab tests are of extremely limited value. You might expect a lactate to be raised, but many times it's completely normal. If it's a raised result on your lactate, that might be very worrying for something that's already progressing quite far. You want to be getting a surgical consultation, letting the surgeons know earlier rather than later if this is something you're thinking about. A normal CT abdomen is going to pick it up, 64%-ish of the time. It's got quite a limited sensitivity. The gold standard is a CT angiogram. This has a much higher sensitivity of 90 to 100%, and it's very specific as well. And you can see here, I don't know exactly what vessel this is. Let's call it the superior mesenteric artery, for example. But you can see that there's thrombus, this darker area, and blood is not completely getting through here, and that will have downstream pain, ischemia resulting from that. So it's not an easy diagnosis. There's no specific exam, history finding, lab test to rule this in or out at all. You basically need to go maintaining a high suspicion, high index of suspicion in certain demographics. If someone's got pain out of proportion to the exam and what you would be expecting, and particularly if they're a bit older and they've got embolic or thrombotic risk factors, keep this in mind because it carries a high mortality. Okay, moving on, we're talking about AAA or abdominal aortic aneurysm. So this is basically where you get a kind of ballooning, an aneurysm within the aorta. The most common type is infrarenal, so below the renal arteries and above the bifurcation of the common iliac vessels. In terms of how we decide whether something is an aneurysm, anything over sort of 3 centimeters is diagnosed as an aneurysm, small, medium and large. These carry different possibilities and risk of having an acute event happen, like a rupture, the specific risks of which are listed here. So you can see anything less than 4 centimeters, a very negligible risk of a rupture, but after that the risk does go up quite dramatically. So just bear that in mind. And when we come on to how these present, classically we're taught, there's this triad of hypotension, pulsatile mass and abdominal pain. Less than 50% of these present in this way. If you've got any one of these three, I would be thinking about it if it's in the type of person that you might be worried about. So they've got a known AAA or they're a bit older, for example. The problem with AAAs is that they can present as masquerades and they can present very atypically. I've read a report of a chiropractor treating somebody for weeks on end with isolated back pain that then migrated to the front and that person could actually feel a pulsatile mass. They were referred on, and I think they were found to have something like a 10 centimeter abdominal aortic aneurysm, which is huge, massive. If you have a retroperitoneal bleed or leak or rupture, the small space within your retroperitoneum and the lack of expansibility means that can actually tamponade off further bleeding, and so someone can present with, for example, back pain, but they won't necessarily have pronounced hypotension or syncope or collapse or anything, but it still might be a ruptured or leaking AAA. Flank pain, particularly in your older populations, be really, really careful about this. Flank pain can be a AAA, a rupture, for example, particularly if there's hematuria. Don't anchor too early on thinking somebody's got renal colic, especially if they're a bit older. I don't know the exact mechanisms, but have read that the actual aneurysm itself pressing on the ureter or the kidney can cause hematuria or hydronephrosis from the back pressure. There can be a dissection, flap into one of the renal arteries, etc. So just be really aware of that, in particularly older people. And obviously abdominal pain plus syncope is a big red flag for AAA. Acute events from a AAA can include pain caused by dissection or an inflammatory process like an aortitis. You can have rupture, and there can be a thrombosis or distal embolization that cause downstream ischemia. How do we actually detect a AAA? Well, palpation can be variably useful. Specifically 22 to 96% sensitivity. So that's probably because people come in all shapes and sizes. Can be difficult to press through somebody's large abdomen full of abdominal fat to feel anything. Depends where the aneurysm is. Is it more like a saccular aneurysm around the back that you can't really feel? Is it a large aneurysm, etc., etc.? But if you detect one, then great, you've felt it and you can move on from there. However, another really useful bedside test is point of care ultrasound. So if you haven't been trained in this, I'd really recommend and suggest that you do, because it's extremely useful and tends to be much quicker than a CT scan. Doesn't 100% rule it out because you have a 95% sensitivity, but it is very specific, and it can be extremely useful. It's operator dependent, as you'd imagine, and if it's a large body habitus and there's a lot of bowel gas, it can be hard to see, but generally speaking, you can get images like this. And you might be tempted to think that this is the aorta and the lumen, but actually, if you notice here, there's kind of this crescent moon shape, and this represents the actual diameter of the aorta, and this bit of shading here is actually a mural thrombus within the aorta itself, and the measurements of that yield a diameter of around 5 to 5.5 centimeters, which is coming onto a large aneurysm. So that would be very concerning in the context of abdominal pain. But basically, as UpToDate says, have a low threshold to evaluate the aorta with POCUS, point of care ultrasound, in patients with abdominal pain, flank or back pain, especially if they're elderly and or unstable. Just really, really bear that in mind. But of course, the gold standard test for this is a CT angiogram. So you can see here, this is a large abdominal aorta with a big mural thrombus inside it, and then this is where the blood is actually able to flow through, as represented by the contrast. Okay, so that's a bit about vascular causes to watch out for. Now, gastrointestinal. So we've spoken a bit about perforation in the initial chat that we had. So there's different ways that perforations can present. They can be acute, sudden onset, people remember very specifically when it came on, or they can be a bit more indolent, a bit more slow burning. For example, if there's a fistula or an abscess that slowly starts to erode through an abdominal viscera. Some of the risk factors and causes of a perforation can include the obvious ones up here. Peptic ulcers, one of the most common causes of a perforation, particularly in the context of steroids, like if someone's on prednisolone for COPD or asthma exacerbation and they're not given a PPI. NSAIDs, if there's a primary inflammatory or infective process that then goes on to develop a complication of a perforation, like diverticulitis. Vomiting can sometimes lead to Boerhaave syndrome or a ruptured esophagus, and you can have free air within the mediastinum and surgical emphysema everywhere, etc. And then just something I really want to highlight is beware of the diagnosis of alcoholic gastritis, particularly in those patients who, present repeatedly. They have a history of alcoholic dependence or excess, and they often get discharged with alcoholic gastritis and nothing bad happens. One of those days, they may pitch up and they may actually have a perforation. I've spoken to a number of different people who have had this exact thing happen to them. So just be careful about known alcoholic excess and labelling as alcoholic gastritis. In terms of the presentation, as I mentioned, it can be a slow presentation or it can be very quick and they can pinpoint exactly when it happened. They may have an acute worsening of the pain and then a sudden improvement from an inflamed organ that might be starting to swell, and then the bursting or the perforation actually leads to a kind of decompressive effect that relieves some of the pain, which actually often starts to come back again and worsen thereafter. They may have a normal examination, so if you've got a perforation that's contained or within the retroperitoneal space, they may have no signs at all. In terms of the imaging that we're going to have a look at, as we've mentioned before, an upright abdominal chest x-ray is, let's just call it 50-50 for actually being able to find something. If you see free air under the diaphragm or other signs of free air or perforation on an x-ray, then you basically need to get a CT scan and follow that up. But if you don't see anything, that doesn't rule it out. CT, as I say, is more sensitive and you can actually localize the source of the perforation. So if we look here, this is a peptic ulcer around here which has perforated, and we've got all this blackness in the abdomen which is free air. And that's an intraperitoneal perforation, whereas here we've got a retroperitoneal perforation just anterior to the right kidney. This small contained retroperitoneal perforation which you're unlikely to be able to feel or elicit any pain specifically from, but still there's something going on in there which needs sorting out. Okay, so that's perforation. Obstruction. This is the second most commonly missed surgical diagnosis after appendicitis. Why is that? Well, they can present in different ways. First of all, just a bit about the causes. If you're a bit older, the causes can be slightly skewed in different directions, but on the whole, a small bowel obstruction most commonly is caused by adhesions, hernias, and malignancies. That's kind of 90% of the causes, those three, for small bowel obstruction. Large bowel obstruction tends to be cancer, or volvulus, or diverticular disease. When we've got others down here, I've listed them off here as sort of gallstone ileus, and that's more common in the elderly. And then different types of stenoses, from inflammatory bowel disease or ischemic stenosis, radiation, etc. And how do these people present? Well, I just want to first off start by saying that the colon can take up to 24 hours to totally empty after the onset of obstruction. So just remember that when you're asking those questions that we've been taught, are they passing wind? Are they opening their bowels and passing stool? If they say yes, it doesn't mean that they don't have a bowel obstruction, because they may still be in that earlier stage where the colon is still emptying itself. People can present with any of vomiting, constipation, overflow, diarrhea occasionally, abdominal distension, abdominal pain, which is classically colicky and coming and going in waves to begin with, and then it becomes more pronounced and consistent as their intra-abdominal hollow viscera, like the small bowel or the large bowel, swell and distend, or if they perforate, and they can have obviously reduced flatus as well. Small bowel obstruction tends to be a bit less distension than large bowel. There tends to be a bit more vomiting, initially gastric contents, moving on to bile. And in terms of abdominal x-rays, they're diagnostic in 50-50. There's a bit of a theme here as well. But about 50% you might be able to see something, and then after that, the other 50% is anyone's guess, really. Large bowel obstruction tend to be a bit more distended, because if you imagine larger bowels further down, so you've got more bowel behind it to be able to fill up with air and to fill up with whatever else and become distended. They can be more constipated, and they can actually vomit initially gastric contents and then bile, and then if it continues, they can start to have feculent vomiting, because that back pressure from the large bowel can push it all upstream, essentially. And then there's this concept of closed versus open loop. So a closed loop refers to an ileocecal valve. So we'll go here. You can see a small bowel here, the ileum and the cecum, and if there's a closed loop, a competent ileocecal valve, then contents from the small bowel can't pass through, and equally contents of the large bowel can't decompress back into the small bowel. So if you've got a large bowel obstruction, maybe from something down here, and you've got a competent ileocecal valve here, then the back pressure is not going to be able to decompress into the small bowel, and you're going to get quicker distension of the large bowel and perhaps be more at risk of perforation earlier. And around 75% of large bowel obstructions are a closed loop variety. And again, with abdominal x-ray, it appears that slightly more sensitive, with an 84% sensitivity on abdominal x-ray for large bowel obstruction. In terms of the questions, you need to ask a few specific ones. Ask if they've had any previous surgery, because this is quite predictive of small bowel obstruction caused by adhesions, with a sensitivity of around 85%. Ask if they've got diverticulitis. Could this be a diverticular stenosis? Do they have chronic constipation issues? This might be a volvulus. Ask if they've had rectal bleeding, if they've had weight loss, change in bowel habits for a longer period of time, etc. Could this be a malignancy? And then CT versus X-ray. Well, a CT is diagnostic of the actual etiology that's causing the obstruction, more so than an X-ray. You can see the transition point, and it's got a greater sensitivity, a greater specificity as well. So that's the route you should be going down ideally. And then I'm not going to go into these, but others include appendicitis, diverticulitis, biliary, etc., etc., etc. This is for your own reading. I just wanted to cover those two ones there. And then finally, looking at genitourinary causes of pain, which you really need to be very aware of. The first one in females is ectopic pregnancies. Ectopic pregnancies are pregnancies that occur outside of the place where they should occur, within the uterus. They can occur in the cervix, lower down, they can occur in the abdomen, the ovary, or in the fallopian tube itself. And worryingly enough, they happen in 1 to 2% of pregnancies. And people can present, again, there's no triad or there's no classic symptoms that definitely nail down a diagnosis of this, but you can have any and all of pelvic abdominal pain, nausea, vomiting, lightheadedness or actual fainting, vaginal bleeding. Any of these can be indicative of a ectopic pregnancy. And so the real take home here is, in order to avoid getting into trouble, any female that comes in of childbearing age, make sure they get, with abdominal pain, make sure they get a pregnancy test to just rule that in or rule it out. That's the main thing to mention on that. So just bear in mind these symptoms, and particularly if they've got any history of pelvic inflammatory disease or previous gynecological surgeries or previous miscarriages, etc. These all leave them at higher risk of an ectopic pregnancy. And that can be life-threatening, really, so just bear that in mind and get your pregnancy test, your HCG, done. Testicular torsion. So there's a bimodal phase to this. They classically present either in sort of the first year of life or around adolescence, young adulthood. And the presentation can be a bit variable. You can have intermittent torsion, so torsion, detorsion, where it's just on the point of going into full torsion and then slightly untwists as well. So just bear in mind that if someone's had torsion sounding symptoms but they're fine when they come to the emergency department, you might want to just be thinking about, could this be a torsion, detorsion? No single history or exam feature can rule in or rule out the condition. This is, again, like many of these conditions, something to keep a high index of suspicion for in this kind of population group. The TWIST score is fairly useful to know. It lists some of the main findings that can accompany testicular torsion. Hard testes, swelling, nausea or vomiting, no cremasteric reflex, and high riding testes. It can help a little bit with, what would you call it, risk stratification. But basically, there's a positive predictive value of around 90% if you've got 5 points on this particular score. So you could have a hard testes, a swelling, and be vomiting. You've got a positive predictive value of around 90%, and it reaches 100% if you've got 6 points or more. So it's useful when you're calling the urological team to say, oh, this person's got a TWIST score of 7 or whatever. It just allows you to have that language to communicate with them. And then there's a near 100% negative predictive value if they've got a very low risk as deemed by the TWIST score of 0 to 2. But I wouldn't necessarily use it to completely rule things out. Just it's there as something quite useful. And the cremasteric reflex, just to go over it, because it can be a bit of an odd one, you're basically just gently stroking the inner part of the thigh and looking for, it's just one stroke, you don't need to go too hard on that at all. And you're looking for the ipsilateral testicle to kind of be pulled upwards by the cremasteric muscle on that side. That's essentially what it is. If that doesn't happen, then it might be a sign of torsion. But actually, it's less sensitive than we once thought. So it's one of those other things that's helpful towards your pre-test probability and building that up. And the window of salvage for these is around 6 hours or less. So really try and nail that down as early as you can. And then finally, sorry, the final wasn't genitourinary, we're on to extra-abdominal. So things that aren't actually in your abdomen specifically. Myocardial infarction. As I've said in the first one, anyone who's got epigastric pain, or you've just got any index of suspicion for, just get the ECG, because inferior MIs can classically present with inferior epigastric pain, with epigastric pain. They can have belching, they can have nausea, vomiting, dyspepsia, a lot of the same symptoms of gastric reflux disease. And actually, there are many cases of people misdiagnosing peptic disease and missing myocardial infarctions. And then once you've got your ECG, depending on your pretest probability, and if you're worried, then consider troponins. But if you see something ischemic looking on an ECG, obviously you need to work that up. If it's a totally normal ECG, then there's a bit more nuance, a bit more grey area there. But these are just to say, do not miss a myocardial infarction thinking it's something like a peptic ulcer disease or something. And this was a case study that showed that somebody presented with an MI and acute pancreatitis at the same time. So that's a pretty unfortunate combination to have. And actually, I had a patient very recently who came in who was a walk-in patient. I think he was in his late 70s, and he said he had a bit of chest pain earlier in the day. It settled down, and it was just a bit of indigestion. Really wanted to go home, looked really well, normal observations, and he was pointing to this kind of epigastric area and said, "Oh, it's just a bit of indigestion. I've had it before." And after his troponins came back, he had basically had an MI. So just bear that in mind for your epigastric pains. And then PE, bit of a weird one. Pulmonary embolism can present with abdominal pain, and up to 11% of PEs do present with upper abdominal pain. It may, annoyingly, be the only related symptom of a PE as well, and it's normally ipsilateral to the side that the PE is on. Some of the possible mechanisms for this include liver capsule or biliary dilatation due to right ventricular strain and back pressure. Pulmonary hypertension may lead to abdominal lymphedema, portal infiltration. There may be some pleurisy from like an infarction, bleeding or exudate from the PE causing inflammation around the pleura. But essentially, it's a tricky one. If you've got somebody with slightly atypical upper abdominal pain, just you can't figure out what else is going on and they're just being a bit of an enigma, make sure you've got an idea of what their saturations are. ECG, as we've already mentioned, Wells score, think if they've got lots of risk factors, and then you may want to start considering D-dimers and CTs, depending on if there's anything else explaining the pain that they're having. And then diabetic ketoacidosis is another one. I'm not going to go into that, but if someone's got vomiting, abdominal pain, just make sure you get a glucose, a blood glucose from them. Okay, so that is the bunch of presentations that we're going to cover there. Now a little bit about elderly challenges. So with the elderly, they're a very specific group who come in with abdominal pain, and as we all know, we're seeing more and more of them increasingly. They can be quite tricky because often with history taking, and I'm not stereotyping here, but there can be a degree of cognitive impairment, and just for people who are even younger, it can be difficult to figure out and track down and remember when the pain started and when it changed from this area to that area and when I started having the diarrhea and things like that. So it can be difficult to get a specific history, and they tend to have a slightly more complex medical and surgical history to muddy the waters as well. In terms of the examination findings, they might not be able to mount a tachycardia that you would be expecting in somebody because they may be beta blocked, they may have cardiac disease that might prevent them from mounting a tachycardia, and they might have falsely reassuring blood pressures, which, however, for them are relatively hypotensive. So someone who's walking around a normal for them blood pressure of 170 over 100, if they come into your department with a blood pressure of 130 over 90, that for them is a relative hypotension. They may have a reduced ability to mount a febrile response, and with sarcopenia, reduced muscle mass, they have reduced abdominal tonicity, and so when you're palpating, you might not be able to find any rigidity when it would be otherwise there on someone who's actually a bit younger. And neuropathy, peripheral neuropathy, reduced pain sensation can be an issue as well. And this is quite a worrying thing, but in patients with peritonitis who are slightly older, only 55% have pain and 34% have rigidity. So again, just highlighting the point that this is all a bit of a tricky thing to deal with. In terms of investigations, a few notes to mention. 30% of older patients who require abdominal surgery have normal white cells. Okay, 30%. In 80-year-olds, clinician ability for an accurate diagnosis drops below 30%, and that's probably because of all the things above that we've mentioned that muddy the water. And in another study of patients aged over 80 with abdominal pain, those who went on to have a CT had positive findings in 55%, and there was a clinically unexpected diagnosis in 43% of those as well. So it's really tricky. So what I would say is, for elderly people coming in with abdominal pain that's ongoing, have a much, much lower threshold for doing a CT scan. What are we doing with CT scans when we're making that decision? Well, it's a risk-benefit. The risk is radiation exposure. They might have contrast allergy. They may have incidentalomas that are found. It may lead to other investigations and over-treatment, over-investigation, etc. But the benefit is that you can actually see what's going on. And if the risk of something catastrophic happening at that moment in their abdomen outweighs all those other risks, it's better to get a CT. So I've heard other people use terms such as CT liberally in older people with abdominal pain. And I would tend to agree that that's probably a better approach than being too conservative with your imaging. In terms of other points, as we've said, normal lab results do not rule out acute mesenteric ischemia. Don't misdiagnose acute mesenteric ischemia as gastroenteritis. Don't rely too heavily on classic presentations of common illnesses in the elderly because they don't present typically. We've mentioned about urinalysis, and we've mentioned about expecting abdominal rigidity when considering a visceral perforation, because that often isn't there. Most common causes for surgery in the elderly are biliary pathology and bowel obstruction. And fecal impaction is not a benign presentation. If someone's come in and they've not been able to open their bowels, don't just discharge them without thinking too much about it. You might be able to, but it's also very reasonable to consider admitting them for disimpaction and management of the constipation, because that can, if untreated, lead to bowel perforation or ischemia. And a Royal College of Surgery's England audit found that almost half of patients undergoing emergency laparotomy are over 70 years of age. So that just shows how much proportionately elderly people are a major risk population for serious surgical pathologies being present. And then consider ischemia in all older adults with abdominal pain. Yes, and here we go. Have a lower threshold for admission. Just think to those patients who have chest pain. They might be a bit older, they might have some risk factors. It doesn't quite sit well with you to discharge them. Have a similar approach for people with abdominal pain. They might just need a bit of observation. Just don't rush to discharge people if there's any, residual concerns, because people can present with nasty things. What's going on here? Why does this always happen? Give me one. Oh my goodness me. Give me 1 second. Right, we're back. We're back in the room. So we're almost done here. 2 more things to talk about. Disposition. I'm not going to go into clear admission. If someone needs admitting, admit them. For discharging, I would say that a definitive diagnosis is less important than the disposition decision. Many abdominal pains do not have a clear organic cause. Up to 40% of people who come to A&E with abdominal pain are ultimately diagnosed as abdo pain of uncertain etiology. Approximately 80% of those who are discharged with this diagnosis of undifferentiated abdominal pain improve or become symptom-free within 2 weeks. Hooray! So just make sure you safety net well for that other 20% who might just need that bit of extra time to see if something's going to evolve. Before you discharge someone, go through your checklist. Have you done enough serial examinations to make sure the abdomen is nice and soft, there's no other positive findings that are concerning you? How's their pain status? Is their pain well controlled? Have they required IV morphine during their stay? Because that's a bit concerning. But if not, and their pain is not too bad, 2 thumbs up. Check their observations. Are the obs reasonable? and just double check those investigations as well. There's no rogue CRP lurking in the background or rogue raised amylase anywhere or lactate. If you can check through all these things, have a discussion with the patient and come to the decision between you that actually doesn't look like there's anything overly concerning here, but if things worsen significantly or you develop worrying new symptoms, then just come back, then that can be a reasonable time to think about discharging somebody. But then we do have these grey areas that we run into many, many times. And as I've said, people who are elderly, higher risk, reflect on that medium high risk chest pain that you admit for a bit more of a workup, a bit more time. Serial examinations are cheap and non-invasive, but they can arguably be the best test. So consider keeping someone a bit longer, going back in to do those examinations, seeing if anything's evolved or changed, because labs often aren't that helpful. And the shared decision making, how far away do they live? Do they have anyone else with them? Are they comfortable going home? Speak to the surgeons if you need a bit more advice and your colleagues, etc., etc. Oftentimes there's not an obvious correct answer. It's a balancing of risk and benefit and that sort of thing. Okay, so to finish off, there's a few pearls. Make sure you treat the pain that you're seeing. There's no evidence anymore, well, there was never any evidence for withholding analgesia to try and get a more accurate examination. Give somebody who's coming in with abdominal pain good pain relief. Oftentimes it does require morphine. And on that topic, if you've given someone IV analgesia, it's not evidence-based, but it's a good heuristic to think maybe they need imaging or surgical consultation because of actually, if they've required IV analgesia, that is perhaps an indicator that there is something going on in itself. And your tools, you've got history and exam, that pre-test probability that we're building up, labs and imaging, and time. Sometimes you need more time. Can you have time with the patient at home, looking after themselves, and they're happy to come back if something changes, or do you need more time to keep an eye on them in the emergency department, in short stay, in a ward or something like that? And it's about knowing the limitations of the tools that you've got at hand. As we've already banged on about, pretest probability is very important. Elderly have a much higher mortality and much more murky presentations than younger population. Women of childbearing age, do that beta HCG test, whether it's your serum or your urine. And abdo pain of uncertain origin is a much better diagnosis than gastroenteritis, which is basically the costochondritis of the abdomen. Don't just force a diagnosis in there. Up to 40% of the A&E attendances are of uncertain etiology, but try not to diagnose a diagnosis of exclusion unless you really have come up against a brick wall and there's nothing else that's obviously concerning. Alright, so I hope that was helpful. That's the end of part 2, and thanks very much for listening.